for airway management. But today I will present about the oral intubation, where the oral intubation is the preferred method for the emergency situation. If you are not experienced in the intubation, you may need to do the bed and mask ventilation before you wait for the help from the experts. So the indication and contraindication. So first, indication of the
Thank you for this comment. It is very important that you need to ventilate the baby, whatever the method. If you are not able to intubate, you can ventilate him by face mask, but whatever is present. Okay, good.
Thank you, Doctor. Okay, so the indications of the ET intubation. So first is the respiratory failure. Either the patient have unstable airway due to infection, anatomical structure, or neuromuscular disorders, neurological disorder. So second is inability to ventilate unconscious patient. So we need to use ET intubation for the airway management for the unconscious patient. So third is the patient with neurological dysfunction, either due to trauma, seizure, metabological disorder, or toxication. And ET intubation also need to do to maintain and protect the intact airway, and also for the diaphragmatic hernia. Because diaphragmatic hernia, we cannot do the bed and mask ventilation. So we need to do the ET intubation for this type, for this disease. So for the contraindication, like I've said before, if we inexperienced in intubation. Okay, then the equipment. So first is laryngoscope. Laryngoscope is for the visualization of the vocal cord and also for the placement of the endotracheal tube. There are two types of the laryngoscope. First is Miller straight blades and also Macintosh curve blades. So Miller and Macintosh, they are sized according to the age of the patient. So 0 for neonates, 1 for infant, and also 2 for child. Usually in infants and neonates, we use the Miller straight blades due to infant flexibility of the infant's epiglottis and also the longer size of the epiglottis itself. Okay. Then equipment endotracheal tube. So there are two types, either cuff and uncuff. Cuff ETT, there are balloon inflated at the tip of the cuff, at the tip of the tube, and uncuff is usually for neonates and infants because we afraid that this inflated balloon may lead to injury to the mucosal lining of the airway. So that is why we use uncuff in the neonates and infants. But cuff tube is to avoid the air leakage and also prevent regurgitation. Okay. Then this is the internal diameter of the ETT corresponding to the weight of the patient, and this is how we use the formula. For the neonates, this is the length on how far we can go into the trachea. This is the formula. And for the size and also the length for the children more than 1 year old. Okay. Then other equipment is ambu bag or bed valve mask to provide oxygenation and ventilation. For stylet or boogie for the guide to the tracheal tube, and this stylet or boogie may bend to fit the curvature of the airway, and then adhesive tape to anchor to maintain the position of the ETT, and then ECG monitoring suction to suck the secretion or any foreign object. Syringe, especially used in the cuff tube to inflate the balloon, and a pulse oximetry to measure the oxygen saturation, megaphosphates for the guide tracheal tube, and also to remove foreign object. So we can also inject the sedation and also muscle relaxation to the patient before we do the intubation. This is the right size and position of the bed mask ventilation. Okay, then proceed to the preparation. We use lemon pneumatic. Lemon pneumatic is to assess the airways and predict the difficulty in intubation. So L is look externally, either there is abnormal facial shape of the facial trauma, or large incisors. So E is evaluate the 3-3-2 rules. So three finger of the mouth opening is to assess the ease of the airway for us to insert the laryngoscope and also to visualize the glottic opening. So, and then three fingers between the mentum in here, and also to the hyoid. It is there to as if there is less than three fingers, so there may be uh, there may be less space for the tongue to displace in when we intubate, or the okay. Okay, then two fingers between the hyoid and also thyroid cartilage for us to identify either we can use direct laryngoscopy or not. Because if there's less than two, we cannot do direct laryngoscopy due to acute angle of the base of tongue and also larynx itself. Okay. And then M, Melampathy score. Melampathy score is the visualization of the soft palate. The class 3 and class 4 is the higher risk of the difficulty in intubation. So, and then O, obstruction of airway due to abscess, foreign object, or trauma. So N is neck mobility. We have to assess during patient is awake and alert. So when the patient is awake and alert, uh, we ask them to place their chin to the chest. So or tilting their head to identify any neck stiffness, because we want to do a sniffing position, because this sniffing position is the perfect position for us to visualize the vocal cord letter. Okay. Then this is the preparation of us and the patient. Um, First is suction. Suction, we need to make sure to have the suction, either we can use open suction tubing without any suction tip at the end, or we can use yarn cover suction at this bit here. So, and then O is oxygen, giving the oxygen supply by using the back valve mask or non-rebreather mask. Non-rebreather mask, we don't need assist them to breathe by using NRM. So, and airway equipment is the one that I have listed before. Patient positioning, like I've said, sniffing position, when the tragus of the ear is aligned with level of sternal notch. And then ME, monitoring equipment, we monitoring the oxygen saturation and capnography. Okay. This is what I've said about sniffing position, where the tragus of the ear horizontally aligned with the sternal notch. Okay. If the patient is obese, we need to do double shoulder roll. We need to place the double shoulder roll for us to be higher, okay, than usual. Okay, then infant, this is for toddler, and also for other child. It's just the same sniffing position. Okay, then I proceed to procedures. So first we take the patient's head back while lifting the chin, and then we open the mouth by pushing lower jaw with thumb and pushing upper jaw with index finger. And then we insert laryngoscope from left side of patient mouth, moving aside the tongue and try to locate the epiglottis. If you use curved Macintosh blade, we will insert between vallicula and also tongue. But if you use this straight Miller blade, we will put it on the top of the epiglottis, at the tip of epiglottis. This is how the differences of anatomical structure of the epiglottis. Okay, in different patients. Okay, this is how we see inverted V vocal cord, and this is our target to insert the endotracheal tube, and we will put this here for the plate. Okay, and then make sure to not pull backward on laryngoscope. or you may do the injury to the upper incisor of the teeth. And then we push forward and outward to lift epiglottis and view the trachea and vocal cord. Okay, if we can't see the vocal cord, so we have to use Selig maneuver by applying pressure on the cricoid cartilage. And this will occlude the esophagus and will help bring the vocal cords into view. But it is not that recommended to use this. Okay, and then we insert endotracheal tube via right side of mouth as not to obstruct your viewing area. Okay, this is what you have to note, that if intubation is not done within 20 seconds, you cannot insert ETT at that time. So you have to abort the attempt. You have to pull back the laryngoscope and re-ventilate with back and mask ventilation until the patient is stable again. So you may do the re-attempt again, the re-attempt of the intubation. Okay. And then while holding the endotracheal tube in place, remove laryngoscope and pull out the stylet from inside endotracheal tube if you insert the stylet before for the guiding of the tracheal tube. But if you don't put, so you don't have to, because stylet is optional, just to guide the tracheal endotracheal tube. Okay, and then we attach the end-tidal carbon dioxide detector and MU bag to endotracheal tube. And then you squeeze the bag at regular intervals to begin ventilation. Finally, secure the endotracheal tube with tape at here or at the cheek, and then we attach ventilator to MU bag. This is how in the PITS protocol, the overview of the procedures. Okay, then we proceed to the complication and pitfalls. So the problems arise in the intubation. There's a possibility of esophageal intubation or right line intubation. If we do the intubation and then we cannot see any improvement to the oxygen saturation, or also we cannot see any color change in the end tidal CO2 in capnography. So there's a possibility as there's a possibility for we intubate into the esophagus or into the right lung only. So like I said, if we do the wrong way, we have to pull back and ventilate, and then we attempt the intubation again. Okay, the complication, it is of course to the trauma to the upper airway, or also trauma to the dental injury, due to dental injury, and pneumothorax, and for the late complication is subglottic stenosis. Okay, I think that is all for me. This is my references. This is for video if you want to see. Okay, thank you. Is there any questions?
Anyone need to ask her questions?
Or you want to see the video, but the doctors do not use the glove, so you can but you can just see the procedure. Do you want to see the video of it?
You will share it to the group because
Because I have
to speak about. Sorry, what do
because I have insert the link at the slides, but if you want to see it now, I can just present that. Do you want?
No, enough to send it. I just would like to tell you many points. ET-tube is a very important procedures, but as you said, its goal is ventilation. Sometimes we cannot, because of anatomical abnormalities or like that, to use it, but we must know it. Okay, there is many advices about. Most of you are using the laryngoscope, which you speak about. Okay, spoke about the laryngoscope. Many doctors are using a laryngoscope as a weapon, not as a pen. We need to use it as a pen, very simply by 3 fingers, by left hand, even if you are right-handed like me. Okay, so you must catch it by 3 fingers, especially in neonates and small children, because most of you are living between the anesthesia team who is bringing a very big laryngoscope and doing a very muscular job. Okay, so for neonates, we must be very fragile, carry it as a pen, not as a weapon. It is very important. The second thing which I need to tell, the endotracheal tube is put under the name of invasive ventilation. Okay, invasive mechanical ventilation. We are going to put a tube and connect it. Now there is non-invasive, okay, ventilation. I don't know if you include it in your presentation or not. After that, for the remaining stuff, non-invasive presentation, ventilation. Okay, so we must be able to present the face mask, the nasal bronch is very important, and some detail about that. And the now, which is a good very acceptance in the practice, is high flow nasal cannulas. Okay, so we need to go for the mask ventilation. Okay, the nasal cannula, the high flow nasal cannula, the nasal CPAP or nasooral CPAP. CPAP is a continuous positive airway pressure. So you must write all this for and present it to me with the next one. Okay? Because this is the start and it covers a big proportion of the patient who needs to be supported by oxygen. Am I clear?
Yes.
Okay, for endotracheal tube, it is a very important procedure, as I told you, and you must be able to calculate the depth and the size also. And usually with ET tube, you must got one size before and one size after. I mean, one size is smaller and one size bigger. Because sometimes you are going to intubate the one which you calculate and you find him is very small. So you need to come 1 degree below. Or you found his respiratory opening and the epiglottis is a bit wide and you are afraid he can get leaking around the tube. So you may need to come for the largest one. I will ask one question for your colleague who presented now. What is the danger if you put the ET tube in the right side, in the right trachea, in the right bronchus?
The left lung do not get the same ventilation and
Okay.
oxygen.
What else, Balkis? Yeah, now this is the omission. This is the omission which you close the left lung. You didn't give her any. You already closed. You make hypoventilation here.
Hyperventilation.
The other side is a commission itself. So omission for the left lung, it will not ventilate it. She will get collapse. And the other side will be commission, which is hyper ventilation, okay, which can cause barotrauma, volutrauma, and pneumothorax, and the air leak. So it is just simple details about the depth of the ET tube. That's why we must auscultate bilaterally to make sure that there is equal air entry. And even that, we need also to do chest X-ray to make sure that it is above the carina. Okay, so that's why it may be just simple Simple mistake about some details, even it looks very basic and essential, it can cause a complication. One lung will be collapsed and the other lung will be traumatized and got pneumothorax. So at the end, it may be the patient will die. That's why to start by the procedure to be very clear to you from theoretical point, and then you will attend with the most professional one during his procedure is a very important. As they said before, see one, do one, teach one. All of us, inshallah, will be very good in all procedures. Is a non-invasive, starting by just oxygen or just high nasal cannula or CPAP or high flow nasal cannula. Okay. Of course, nowadays with the issue of COVID, we are trying to decrease most of this one. Why? Why Farah? This is our Farah. Farah Shaira. Is it student? Or this is our science officer?
I think it's the science officer.
Okay, so Nur Sufiana, can you answer the question?
What was the question again, doctor?
Where are you? Who can tell her the question?
I also didn't hear it clearly.
Okay, if you didn't hear, you need to ask me, please, to repeat, because sometimes the internet is not very helpful. Okay, so now we need to come back and remember us by preparing the non-invasive, okay, ventilation, non-invasive ventilation, which is a very, very important one. Okay, let us go for the next presentation, because it may be after 20 minutes we can end, inshallah, our meeting. I have another meeting at 4. Who will be the one?
Me.
Umaira?
Yes.
Okay, go ahead, Umaira.
Ya, Assalamualaikum. Sorry. Okay. Ya, Assalamualaikum warahmatullahi wabarakatuh. My name is Wan Umairah binti Wan Muhammad Yusuf, and I'll be presenting about the weight, height, and occipitofrontal circumference. For occipitofrontal circumference, it is also known as head circumference. So here is the anthropometric measurements, the weight, height, and head size according to ages. And it is important for us to know the growth of the child in order for us to know their healthy development, and also to identify any nutritional or health problem. So we go to the weight assessment. For infants less than 2 years old, we use the calibrated beam or electronic weighing scale. As for the technique, the infant should be weighed nude, and and we also remove the diaper, and ideally we weigh them before feeding. And on the electronic scale, we have the average weight feature, which is to accommodate the infants who do not remain still during weight measurements. And the weight should be recorded to the nearest 0.1 kilogram. For children above 2 years old, we use the standing beam balance or digital scale. For the technique, the child stands on a beam balance or digital scale unassisted by anyone. And then the child is wearing light undergarments or light wear outer clothing. And the weight is recorded to the nearest 0.1 kilogram. And for additional note, children who are unable to stand unsupported may need to be weighed while being held by someone. And then we minus the weight of the person who assists the child. As for a larger child with special needs, they may need to be weighed on sit-down or wheelchair scales. This one. Now we go to the length and height. For infant less than 2 years old, we use a calibrated length board with a fixed headpiece and movable footpiece that is perpendicular to the surface of the table. As for the technique, 2 people are needed to get an accurate measurement, like a guardian and a doctor. And then we measure the infant without shoes and wearing light underclothing or diaper. And the infant should be placed on its back with parents or guardian holding the infant's head against the fixed headboard, and the infant is looking up. And simultaneously, the health professional should strengthen the infant's leg and record the length to the nearest 0.1 centimeter. As for children above 2 years old, we use a stadiometer for height measurements, and it requires a wall-mounted vertical board with attached metric rule and a horizontal headpiece that can be brought into contact with the superior part of the head. And for the technique, we measure the height for children over 2 years old who can stand unassisted by anyone. And then the child stands against the stadiometer without shoes and heels together, the legs straight, the arms at sides, and shoulders relaxed. Then we ensure the child is looking straight ahead, and we bring the perpendicular headpiece down to touch the crown of the head. And the measurer's eyes are parallel with the headpiece. Then we measure to the nearest 0.1 centimeter. Additional note, for a child with special health needs, they are monitored with special skills and equipment and conducted at certain pediatric center. Now we go to the occipitofrontal circumference or head circumference. It is done until age of 3, and for the equipment, we use a flexible, non-stretchable tape. For the technique, we sit the infant on adult's lap and keep the infant's head still during measurement. And then we use the flexible, non-stretchable tape. We measure from the bony protrusion from the back of the head or occipital prominence. And we bring the tape around the head and position it just above the eyebrows at the frontal prominence above the ears. Then we measure to the nearest 0.1 centimeter, and if possible, we repeat the measurement 3 times to ensure the largest circumference and the correct reading is recorded. Here are the examples for the growth chart. This is for boys growth chart, girls growth chart, and preterm growth chart. So I will explain briefly on how to read or how to use the growth chart. First, look at the top of the growth chart and make sure you choose the correct one. Here, look at the top. For example, this one is from birth to 24 months, and this chart is for boys, and the content for this chart are length for age and weight for age percentiles. And then we look at the age. For age, we have at the top and bottom. Here, the age at the top and also the age at the bottom. This one. Then we look at the length in inch. For the length, it can be in inch and centimeter. And so when we plot the graph, if you follow the line to the right side, we will see there is small numbers at each line, which is the percentile. For example, if the child is 24 months and 37 inch length, so he will be at the 98th percentile. And most of us will be at 50th percentile, and those who are smaller than average will be on the lower line. And if we are larger than average, will be the upper percentiles. And we also can do the measurements for weight. As for weight, it can be in kilogram or pound. So we do the same. We plot the chart and we can see the percentile. And here are my references, and I think that's all from me. Is there any question?
Thank you, Umaira. It is, in spite, it looks very basic, really, but we are suffering from inaccuracy of it a lot. Let us, if someone measure the baby by incorrect way, either the weight, either the height, even to get the height for child, where he must stand up without anything, he must touch the wall by his heel, by his buttock, by his shoulder, by his head, and they must look at a 90-degree vision, not up, not down. That's why we can get the accurate measure. To put inaccurate measure during your serial measurement, and you must take care about that. I think we must have lecture about growth and development. We will not accept single measure, okay? Because I may have two childs came to me now. Both of them are on the fifth centile, 50, fifth centile, okay? But when I got the previous measures, I found one of them was on 90 or 95 centile and they came in fifth. And the other one was in 10 and they came to the fifth. Is it the same diagnosis? Is it the same? No, no. The first one, I tell them, oh, your child is losing weight. I would like to investigate what happens. Maybe the child is obese, or the family try to adjust his weight, or what is the issue? If he has got a chronic disease, so I must investigate for that. The other one, I will say, oh, very good. Your child now started to pick weight and the fifth centile. I am very happy with that. So they call it gross chart. It is not one point. It is a centile. Other name is centile chart. I must see. Sometimes I will find someone in the same centile. I will say either it is familiar or constitutional, and they may accept because he is follow the same centile for a long time. Okay, that's the most important. If someone make a wrong measure about the height, even sometimes some put the baby like that just on the scale and leave him without taking a breath to adjust it. If the one doesn't, we must know even in units, we must know how much is the weight of the bumpers. Is it 28 milligram if I'm going to weigh him with a clean bumper without, or even if I weight him, I must remove the bumpers and weigh it and deduct. Simple things will affect. Even Umaira speak now about the head circumference. Head circumference is different. Many measures you are making repeated just to get the mean, but the head circumference, because it is bone and fixed. If I measure and got it 40 and you get it 39, I must consider 40. Okay, that's why we are measuring for the head circumference 3 times and we retrieve the biggest one. Okay, so thank you. It is very basic, but you must share all and after doing a correction which we spoke about, you will share it to the whole group together, inshallah. Okay, so I think our time now is near to finish. Let us revise today how many activity we did.
5.
Hmm?
5 procedure.
Okay, what is the remaining for the next time with you, other than the one which I asked for?
4 procedure more.
What is the title?
The title is lumbar puncture for 1.
Okay,
Lumbar puncture, ECG, long percutaneous line insertion.
okay. The last one?
The last one I didn't know yet. We didn't know yet.
What about the blood culture?
Seems like our 9 of us none choose blood culture. None of us choose blood culture.
It must be done the blood sampling and the blood culture. Okay, it may be just blood sampling for normal sampling, full blood count like that, or blood culture for more precaution. It must be included. And it is non-invasive. And I send you in the group about some procedures or not?
Yes. Yes.
If you feel other are suitable, for me, no issue. If even everyone did one more procedure and we discuss, I will be happy to know that you know what is the importance of your skills in your hands. This is your actual value. To have skills, not to have a pen only to write medication. Okay. Our next meeting will be on
Friday night.
Yeah, it is either
7:30.
maybe after Maghrib, like around 7:30, inshallah. Okay, hoping nothing will be happen. I'm on call. I will be must be around, inshallah. Okay, just prepare good, and if any one of you has any correction, please try to make it, and see you inshallah soon. You have a good timing now, 4 days to finish every job. You can come back to the other procedures, and if you add, I am welcoming to discuss it with you. Okay. Don't forget also to write for me every name and what he present, and send it today, and inshallah the next batch will be on Friday. Okay.
Okay, doctor.
Okay, thank you.
Thank you so much, doctor.
You are welcome.
Thank you, Doctor.
Thank you so much,
May
doctor.
Allah, inshallah,
Thank you, doctor.
give you.
Thank you, doctor.
You are welcome. Assalamu alaikum warahmatullah.
Assalamualaikum.